Welcome back, Excellencies, distinguished guests, ladies and gentlemen. Next, we are honored to introduce our third keynote speaker, Prof. Dato Dr. Zulkifli bin Muhammad Zainuddin. He completed his medical training at the National University of Malaysia UKM School of Medicine on 1998. Master in Surgery, National University of Malaysia 1998. He continued his study in fellowship in Urology, Department of Urology, Royal Adelaide Hospital, South Australia. Currently clinical practice as board certified consultant urology unit at Hospital Canselor, Tuanku Muhriz, UKM. Without further ado, I would like to invite Prof. Dato Dr. Zulkifli bin Muhammad Zainuddin to give speech entitled Approach on Erectile. Please welcome, Doctor.
Yeah. Thank you, Mr. Chairman. Assalamualaikum and good morning, ladies and gentlemen. Okay, so I know this is a circumcision conference, so my topic is a bit different, yeah, from circumcision, but we are talking about the same organ, yeah. So I will be talking about approach to erectile dysfunction. I'm sure most of us or all of us have experienced looking after patient with ED. So, but before that, I just want to ask you, when you talk about the, orang kata, what would be the best penis ever lah, kan, if you ask a man. So when you ask a man about that, of course they want a penis that is very long and very hard. Okay, so you can do acrobatic on that. They also want a penis that they can have sex anywhere and anytime. Yeah, but sadly the reality is this. So people are suffering from this problem, which is what we call erectile dysfunction or ED. So what is actually ED? So we'll go back to the basic definition, ladies and gentlemen. It is actually the consistent or recurrent inability of a man to attain and or maintain a penile erection sufficient for sexual performance. So this is the definition of ED, because sometimes patients confuse us with premature ejaculation. They say they have ED, but actually they have PE. So this is the definition that we have to bear in mind. And as we know, this is the general causes of ED. We can divide into two. There is organic and psychogenic. So mainly, our patient mainly in this criteria, where, as you know, organic ED, the main cause is vasculogenic, neurogenic, most likely secondary to hypertension, diabetic, can be due to hormonal problem, for example, like testosterone deficiency syndrome, and also due to penile injury, disease, and don't forget about medication. We also have another group of ED, which is called a psychogenic ED. This is a type where the patient is a bit younger, or maybe, you know, it's a secondary after they have a good sexual performance. And mainly, the cause of psychogenic ED is actually depression, performance anxiety, for example, like the newlyweds, you know, relationship problem, psychosocial problem, psychological distress. So we have to differentiate which category our patient is in, either organic ED or psychogenic ED, because the management is different. But most of the time, sometimes there will be mixture between these two. Patient can start off with organic ED but later develop into psychogenic ED. So what is actually our problem with ED? This is our problem with ED. As you can see from the slide, this is a study that been done in United States. About 90% of men does not want to seek treatment or never care about the ED problem. Only 10%. And what about back home in Malaysia? This is a study that we conducted a short while ago. We asked a patient whether, you know, we asked a random man, yeah, have you experienced erectile dysfunction? We explained to them what is erectile dysfunction, mati pucuk and all that. So you can see, in Korea, it's about 54% of men said, yes, I have ED. In Australia, it's about 46%. But in Malaysia, ladies and gentlemen, it's about 7%. So do you think we can accept this or not, the numbers? I don't think so. Because this reflects that our men does not want to admit that they have ED. So this is a problem that we have to tackle. And you can see from here, this is a very old study done by LPKKN. So in this survey, it's a national-wide survey. We have not repeat one since. Yeah? About 47% of Malaysian men above 40%, above 40 years old, are affected by erectile dysfunction. So this is some quite serious figure. And WHO have predicted, we are here in Asia, in 2025, there will be 199.9 million of men will suffer from ED in Asia. So it's really, really a huge number. And we have to bear in mind that this is what happened in our daily practice as well. Because you can see from this survey, age 45 years old and above, 38% of men never talk to their physician about their ED problem. So they come to you with diabetic, they come to you with hypertension, but never talk to them, never talk to the doctor about that. And you can see from here, 86% of patients initiated the conversation themselves, meaning that we, as a medical practitioner, also doesn't want to discuss ED with our patient. So this is something that we need to look into, we need to look back, and then we might need to change our attitude regarding this. I'm sure if a patient comes to you with diabetic or hypertension, if you ask them, most of them will have ED. And you can see from here, they have to wait about 2 years before they come forward for ED. And I'm sure, have you know, in my practice as well, there's a lot of orang kata proses bercerai and all that because of this issue nowadays. So a lot of problems suffering from there. And we are competing with this, you know, so this one we cannot compete with them. So because they have very good promotion, they have very good testimony, but as you know, testimony is the worst kind of evidence ever. And also this one, urut batin, we have seen complications secondary to urut batin. For example, like penile fracture, penile bruises, and we also know as a medical personnel, urut batin does not cure ED. So, but we cannot compete with them because they are too good in promoting themselves. So we ask ourselves, is ED a serious disease or not? The answer could be yes, the answer could be no. Because why? No, because there is no life-threatening condition. It is not a life-threatening condition. It is not a morbid condition. And there is no obvious, immediate or noticeable disability, meaning that it's not like orthopedic problem. If you have knee pain, you walk one side, you know, saying it or something like that. Not ED. So ED is just quietly in the pants, like some of our patients said. But yes, it is a serious problem because a lot of studies have shown that it is associated with diabetic, hypertension, coronary artery disease, obesity, which is a main problem now, and that it affects overall quality of life worse in certain culture, meaning that our culture, Asian culture, and give men a lot of psychological trauma. And you can see, as I mentioned to you just now, this is a study that has been done to show that ED is related to all these kind of diseases. High blood pressure, angina, high cholesterol, diabetic, depression. So these are the ones that patients suffering from ED. And also, nowadays, a lot of studies show that ED is actually the first sign of cardiovascular disease. So meaning that we cannot ignore patient who comes to us with ED. Because why? This is the theory of the vascular theory. We call it the artery size theory. You imagine, ladies and gentlemen, this is the penile artery. Penile artery is the smallest artery in our body. So if it gets blocked, penile artery will get blocked first, and then it will manifest itself as ED. The second artery that get blocked is actually a coronary artery. And you can see, of course, if coronary artery got blocked, the patient will have angina or chest pain or even myocardial infarct. So this is the theory to show that we cannot ignore ED. And a lot of studies that have been published, it shows that in majority of patients with ED, ED will precede coronary artery disease by 2 to 3 years. So it will give us a window period to prevent patient from getting coronary artery disease. So meaning that penis is just like, you know, you check your minyak hitam kan with this dipstick, so it's equal to penis. If the penis is not healthy, your body is not healthy as well. So how to manage erectile dysfunction? Of course, we don't have to resuscitate like this. WHO have given us a simple guideline. Yeah? So of course, the first one is modify the risk factor and causes. So if ED does not resolve, you can go to oral agent, yes, sexual counseling, education. If it's still not resolved, then we move to the second line of treatment, which is the local therapy. This include intracavernosal ejection, the vacuum, and last resort is actually surgical treatment, which I will go through one by one with you. So when the patient comes to you with first presentation with erectile dysfunction, so this is the basic workout like any other disease again. So we have to talk about medical history, about psychological history, sexual history. We will do some physical examination, especially we just want to identify whether the testis is sort of like in a normal size. Is there any problem with their body habitus? Because sometimes these people are having testosterone deficiency syndrome. And some basic lab tests, for example, like blood sugar, blood cholesterol, testosterone not yet, not during the first visit. Yeah. And the problem is that our patient normally comes alone, but the most important thing is that we need to talk to their partner as well, because we need to feedback the feedback from their partner. But most of them, in our culture, most of the patient will come on their own, and they did not inform their wife about their health problem, about them seeking treatment for erectile dysfunction. So when we talk to them, these are the things that we just try to focus. Is there any major risk factor for ED? Of course, when you age, there will be progressive decline in function, especially sexual function. There might be some psychological issue. The wife is not interested in sex anymore. These are the chronic diseases that you need to screen. And of course, these are the unhealthy lifestyle that contribute to erectile dysfunction. And we have to be aware, some of the medication can cause erectile dysfunction. For example, like the common one, like beta blocker, sort of like psychotropic drugs. Of course, here, cimetidine, the basic drug also they said can decrease the libido. Anti-androgen, of course. So these are the things that we need to review as well. If we change the medication, they might improve the ED problem. And in any other diseases, of course, this is the advice that normally we give to our patient. Most of the time they didn't follow. Stop smoking, limit alcohol, healthy diet, exercise regularly. So these are the things that we need to tell the patient in all the diseases. But these are the ones that we need to tell the patient to bear in mind, because they are not young anymore. So when men are not young, so they need a longer time to get an erection. They need a direct genital stimulation to get an erection. If you are like 18 years old, you can see a woman, attractive woman walking in front of you, you can get spontaneous erection already. But if you are 80 years old, you need to have a lot of rubbing to get the genital stimulated. Orgasm and ejaculation are less intense. I'm sure you have come across a lot of patients in their 60s, 70s coming to you saying that their ejaculation is not as strong anymore, their volume of semen is decreasing, but that one we cannot do anything about it because it's part of aging. And of course, the refractory period is also increasing. Refractory periods meaning that you get to the time that you get another erection after ejaculation. Again, when you are in your 20s, maybe refractory period is about 3 minutes. But in your 80s or 70s, the refractory period can be 3 months or 3 weeks. So they have to understand that, so they are not young anymore. And we also have tools to help us to sort of like grade the ED, because we want to know roughly, is it moderate, is it mild, is it severe? So it is a questionnaire called International Index of Erectile Function, or what we call IIEF. In Malaysia, it's been translated to Bahasa Melayu and in Chinese. So it was developed in 1998. So normally, we ask the patient to fill up the form before we meet them, because after that, we can score. Severe ED is about 6 to 10, moderate ED is 11 to 21, mild ED 20 to 25, no ED 26 to 30. And after that, we can translate into this. If the patient doesn't want to fill up the form, the other option is what we call the erection hardness scale, which is a bit subjective, you know, because we ask the patient, is it number 1, number 2, number 3, number 4? And number 3 is sort of like suboptimal, suboptimal erection. So when talking about treatment of ED, there are 2 potentially curable ED that we have to bear in mind. The first one is what we call a psychogenic Idi, which I mentioned to you just now in the beginning of my talk, which is a younger patient, doesn't have any comorbidity. The ED is because of some issues with psychological. So in this type of ED, psychosexual therapy and in combination with other therapeutic approach will help them. The second group that we can see in a bit elderly patient, but sometimes I see nowadays more younger and younger men are suffering from testosterone deficiency syndrome. So testosterone deficiency syndrome, the main presentation is actually ED and loss of libido. So in this kind of patient, we can replace their testosterone, and of course, by replacing the testosterone, it will help the erectile function. So these are the things that we need to look into. And but of course, if you suspect a patient to have testosterone deficiency syndrome, we need at least a serum testosterone to confirm. So these are the 2 conditions that is potentially curable. But the rest of the ED problem, that we cannot cure ED, and they depend on medication. And as you know, the first line of treatment is PDE5 inhibitor, because I'm sure how does you know how it works. It's actually a vasodilator that works on the nitric oxide GMP mechanism to help to restore the natural erectile function in the presence of sexual stimulation. So this is the thing that we have to explain to our patient as well. They need sexual stimulation. And then this medication, as you know, it is actually practically a vasodilator. And the first which has been licensed is actually, as you know, is sildenafil or Viagra, which is authorized in 1998. And then after that, there are few followed through. So these are the few sort of like, you know, PDE5 that is available in the market. Tadalafil, this is by Eli Lilly, 20 milligram. I will go through with you after this, the pharmacokinetic and all that. Levitra, vardenafil by Bayer, but now this medication is not as popular anymore. Then I'm not sure, it is not as popular as before. And of course, the oldest in the market is Viagra, which already lost its patency. So when Viagra lost its patency, it's actually a good news to all of us, because now we have generic Viagra. So generic Viagra, for example, in HCTM, we have these 2, which is called Andros and Ignite. So the efficacy is almost the same, but the advantage is that it is very, very cheap. In UKM pharmacy, they sell Andros 6 ringgit per tablet. And then in the tablet, they have, in the box, they have 4 tablets. So it is very affordable now to our patient, alhamdulillah. So efficacy are much the same. Sometimes they respond to 100, sometimes they respond to 50 milligram. But as you know, the starting dose is 50 milligram. As you can see, PDE5 inhibitor are not the same. So we thought it is in the same class, but it is not the same. Because why? You can see that this is important before we prescribe the medication to our patient. Because we want to know what we call the sexual ecology. How active is the patient? If for example, if you can see here, tadalafil, the Tmax is actually 2 hours, meaning that the medication will reach the full concentration after the patient taking it for 2 hours. Maknanya mungkin you want to tell the patient, before sex, you have to take it 1 hour before. So you can see, sildenafil is about 1 hour, vardenafil is also about 1 hour. And T-half, the longest is actually tadalafil, 17.5 hours. Whereas sildenafil and vardenafil is about 4 hours. So the window period for the patient to have sex is about 4 hours. So for those who have sex regularly, meaning that almost every day, the most economical is actually when you prescribe them tadalafil, because they can use it 2 days in a row. Actually, tadalafil is even called the weekend pill. Weekend pill, meaning that they solo on Friday, so they can have sex all the way until Sunday, because it's 36 hours kind of window period. But the problem is that if they develop side effect, it is longer for them to eliminate the side effect. So for me, I rasa if the patient are naive to PDE5 inhibitor, better we start with the short acting first. And then if they are comfortable with the short acting, then you can upgrade to long acting. But with the cheaper, what do you call that, PDE5 inhibitor now, I think that is not a concern anymore. Okay, so I'm sure you also heard about this medication, Cialis 5 mg. Cialis 5 mg is still tadalafil, and this medication can be used for patients who have ED and BPH, meaning that it's like 2-in-1 kind of thing. Because the study have been shown that there is also PDE5 inhibitor located at the bladder neck. So when you give the patient this medication, it will settle 2 problems. The flow will be good, and then the erection will be better. So as you can see from here, this is actually intertensional prostate scoring symptom, meaning that symptom score, this is the improvement of the sort of like quality of life when the patient is having BPH. So this study have shown that when they start tadalafil 5 mg, you can see that there is improvement in IPSS. And of course, as we discussed just now, IREF, by giving tadalafil 5 mg, it is also improved the IREF. But this one is still expensive, but it's good for patients who have both BPH and erectile dysfunction. There are a few sort of like dietary restriction. As you can see, sildenafil or Viagra, the Cmax of the absorption is reduced by 29% when the patient is taking fatty meal. So meaning that for those patients who you want to prescribe Viagra or the generic sildenafil, try to avoid taking fatty meal before sex. Same, vardenafil is about 80%, and then tadalafil is not changed, meaning that tadalafil you can take with anything. So what are the common side effects of PDE5 inhibitor? These are the things that you just need to explain to your patient, because it is actually a vasodilator, so mainly most of them will have the same kind of side effect, which is facial flushing, nasal congestion, headache, and dyspepsia. But not all patients will have this, as you know. And you can see that the percentage is actually quite low, and the side effect is tolerable. So you can see, because tadalafil 20 mg, the dosing is higher, so you can see they have more percentage of patients having headache as compared to sildenafil 50 mg. But the rest are all less than 5%. And the degree of dropout or adverse event is also very, very low. So practically PDE5 inhibitor is safe medication to give to our patient. However, the only contraindication is when our patient is on nitrate. So we cannot prescribe PDE5 inhibitor when our patient is on nitrate because of hypotensive effect. So we want to make sure that. So if your patient is on nitrate, we have to move to the second tier of management, which I will discuss after this. So do not give our patient PDE5 inhibitor when they are on nitrates. Yeah? Okay, so when you give PDE5 inhibitor, these are the things that you need to tell them. They need a sexual stimulation, meaning that by popping Viagra and all that, the penis just not automatically comes out. You know, they need sexual stimulation. Proper time to take medication. As we know just now, 1 hour, maybe 1.5 hours. Some older patients need longer time. Need patient, meaning that sometimes they need 3 or 4 dosing before it is effective. Of course, avoid sexual attempt when fatigued, drinking or smoking. And of course, when taking this, you have to encourage the patient to be optimistic. Sometimes they need at least 6 doses before we change the medication. So what happens if PDE5 inhibitor doesn't work? We have a second tier, which is what we call the vacuum devices. Yeah, the vacuum devices. These vacuum devices will create a negative pressure around the penis. They initiate a passive engorgement. You can see passive engorgement because they suck out the blood from the sinusoidal spaces and creating an erection. Yeah? So the maintenance is facilitated by application of a rubber cuff worn around the base of the penis so that it will prevent the venous return. It is actually very effective, but most of the patient doesn't like it because of the discomfort of the, what do you call that? The rubber cuff, yeah? So instead you got a hot and red penis, you got a blue and cold penis, but it is erected, you know? So it looks like this. So this is a modern one, battery. This is an older generation pump, but these are the ring that I refer to just now. So they just need to put the vacuum device and then pump. What will happen is that the penis will get erected, and then to sustain, you have to block the venous flow by putting in the rubber band. So the feedback from the patient is not really comfortable. Yeah? It's not really comfortable, but this is another safer option lah, as for patient yang on nitrate and all that. The second one, which actually I use this a lot in UKM, which is better than vacuum. It is actually intracavernosal injection. Yeah? So we inject a vasodilator in the smooth muscle of the two corpora cavernosa. This injection will cause erection within 5 to 15 minutes despite no stimulation, meaning that patient will get spontaneous erection. But also the issue is that the efficacy rate are about 70%, which is very good. Dropout rate could be higher because some of the patients are not comfortable injecting themselves. Sometimes they ask their wife to do it. They have to do it for them. But the other common complication is actually penile pain, prolonged erection, or what we call priapism, and fibrosis. So that's why before you prescribe this medication to the patient, you have to ask the patient to come to the clinic, we inject, and then we don't ask the patient to go home first. We need to see how long they will get detumescent. So this is very important because you don't want the patient to get priapism. And nowadays, of course, the needle is not as big as this. Now we use insulin pen, which is much more comfortable to the patient. So which is much more kinder to the patient. This is an old picture. Of course, this is much more painful, but now we use insulin pen. And the third one, let's say we have exhausted all the options, surgical will be the last resort because this involves putting in penile implant. And the surgery is actually quite straightforward, but the thing is that we are worried about complications. So there are two types. This is what we call semi-rigid penile implants. Yeah? For this is actually quite cheap, cheaper as compared to the second version. So as you can see, it looks like a rod. So this one will be inserted into the corpora. But the problem is that patient will have erection most of the time because of the rod. So when they want to have sex, they just pull it up, and then after they finish, they just pull it down. This one, no stimulation, nothing, you know. So it's ready erection all the time. So if you want something different, we can offer this to our patient. This is what we call penal prosthesis. A bit complicated because it involves reservoir. You know, so what you do is that there is a button here. So when the patient is ready to have sex, he will push the button. So you will get the water will be pumped into the flaccid cylinder, and then of course after that they have a full erection. So this is a more sort of like natural, but the price is a bit expensive as compared to semi-rigid. So you can see, you know, cosmetically it looks the same. But of course, this is a last resort because the surgery is a bit complicated. There is also worry about infection, where when infection occurs, we have to take out the whole thing. So we really have to be careful in that. We rarely do this because in Malaysia, the insurance does not cover this. Patients have to buy on their own. But as you know, certain VIP and all that will have this inserted lah. Especially they want to have a younger wife and all that. So this one, no issue. You just press the button. But I just want to tell you one story lah. Yeah, this very rich guy. He also have problem with urinary incontinence because he had his prostate removed. So we insert penal prosthesis. We also insert artificial sphincter, which also require a button. So he have to remember which button to push, because if push the wrong button, he will pee inside instead of getting an erection. So we really have to remember. We also have to tell the mistress which button to push because he's quite old, 80 years old. He cannot remember sometimes. So this is the story behind it, lah. Yeah. Okay. So I'm actually at the end of my talk. So as a summary, we have to know that ED can be treated. So it's our role to ask the patient to come forward about ED. After this, I hope everybody, when we see patient with hypertension, when we see patient with diabetes, we got to ask about ED because this is our opportunity to catch them before they develop coronary artery disease. Of course, proper history and physical examination is crucial. Don't forget to screen for cardiovascular disease because as we discussed just now, ED precedes coronary artery disease within 3 to 5 years. The first line treatment is easy, is PDE5 inhibitor, and then it is actually now very affordable. And of course, if PDE5 inhibitor fail, there are also other options. So as we know, as the day goes by, there is a campaign about save the whale, but now there is so much problem with men. Men are getting extinct, men dies very early. So I thought that we need to change a bit. Instead of save the whale, we need to save the male. Thank you very much for your kind attention.
All right, thank you, Dato. Now we are pleased to open the floor for the Q&A sessions. Is there any question from the participant? Feel free to ask by using the microphone we provide.
Doctor, my question is, what about ED as coming as preventive health care? So we only concentrated on the basic thing like hypertension, diabetes, obesity, hyperlipidemia. Yeah. Why can't this also be included in the preventive health care? Like the American Heart Association include ED as one of the preventive health care. Thank you.
Yes, thank you, Doctor. It's actually, we sort of like have a team collaborating with Kementerian Kesihatan. We actually have launched the blueprint the other day regarding men's health. And then, yes, Alhamdulillah, ED is being put into one of the disease that they need to screen if they see a man in KKM healthcare clinic. So Alhamdulillah, we are getting there. Yeah.
Okay, next question, please. Is there any question from the participant? Last call. Okay, good. Okay. Second question.
Assalamualaikum, Dato'.
Waalaikumsalam, Mr. Syukur.
Long time no see.
Yes, it's been a while, yeah.
I think about more 20 years now.
Yes, that's right. It's so good to see you.
I'm an orthopedic surgeon and spine surgeon, by the way, from Seremban. Right. My question, number one, you have any studies regarding erectile dysfunction and spine problems? Number one, is there any studies going on? Number two, I often see a lot of patients, young patients sometimes with just a mild disc problem, lumbar disc problem with erectile dysfunction, sometimes very significant. And I don't know who to refer them to. My urologist in my hospital do not accept erectile dysfunction. So I don't know who to refer to. Maybe I can refer to you. You have any erectile dysfunction clinic in your hospital?
Yes, we do. We do have a men's health clinic, Mr. Chuko. To answer your first question, of course, there's a lot of study regarding ED and spinal cord injury sebenarnya. Of course, as you know, patient with spinal cord injury will also have ED because of their injury. But there are also studies to show that the ED, which is in a younger patient, is due to pain actually. Because of the painful situation that they're suffering, most of them will have ED because they cannot perform satisfactory because of the back pain and all that. Of course, this patient, I'm sure if you treat the main problem, this is what we call like a psychogenic kind of issue lah kan. So they will improve in terms of their ED. But of course, those with spinal cord injury, we need to help them with PDE5 inhibitor. Most of them require intracavernosal injection. So I think for the younger one, maybe if you treat the pain and all that, their ED will be better. I'm not sure why your urologist doesn't want to treat ED kan, because this is part of urology, but of course we have erectile dysfunction clinic. We call it a men's health clinic. We also see other cases, for example like premature ejaculation and testosterone deficiency in UKM. So if you need my help, maybe I'll give you my number today to you.
Thank you very much, Dato.
Yeah.
Appreciate that.
Yeah, no worries. My pleasure.
Okay, please welcome for the third question.
Assalamualaikum, Dato.
Waalaikumsalam.
With regards as our topic on circumcision today,
Yes.
is there any correlation study on circumcision and ED? Either it's a normal circumcision or complicated circumcision.
Yeah. Actually, itulah I pun ada juga try to look a bit about this. The relationship initially in the beginning is more towards PE because of after you do circumcision, the gland will be a bit sensitive, and then some of them are reluctant to have sexual intercourse, which we can label as a psychogenic Idi as well. But from this study, after a period of time, once the hypersensitivity has gone, then the penile erection should be normal because we are not touching anything. I mean, when we do circumcision, we don't touch the nerve, we don't touch the artery. Kan? So there's one theory regarding the gland hypersensitivity after you remove the foreskin. But I think all those are temporary, doctor. So it should be settled on its own.
Okay. Is there any question from the participant? Last call. Okay, I think that's all. Dato, is there any last word or advice before we end this session?
I hope everybody start asking our patient regarding ED lah kan, because it is really, really important. And patient, most of them won't open their mouth until we talk about it. But we also felt sometimes should we ask about it or not? Sometimes nanti patient kata kita busybody, kan? But the way how we ask lah, I think that's important. Yeah. Thank you very much.